Welcome back to the Scoliosis Dialogues, the official podcast of the Scoliosis Research Society. I'm your host for the episode today, and I'm Grant Hogue from Boston Children's Hospital. We have two exceptional guests on the podcast today, Larry Lenke and Carl-Eric Aubin. They're going to be discussing the new SRS-Lenke-Aubin 3D classification system for scoliosis. And so for those of us that spend a little time in the operating room, we know that the Lenke classification has really been our North Star for the last 25 years. It's how we talk, it's how we plan fusions and AIS, and it's how we teach our residents and fellows. But I think every surgeon knows that a 45-degree Cobb angle on a 2D film only tells a fraction of the story. We've all seen cases where the hidden rotation or the sagittal flattening completely changes the mechanical feel of the spine or even the outcome of the case. And so today we want to discuss a landmark evolution of the classification. Dr. Lenke has really defined the current era of AIS surgery, and Carl-Eric has brought in the engineering mindfulness to push 3D modeling into the clinical and research spotlight for the future. So thank you both for being here today.
You're welcome. Glad to be here.
You're welcome.
Thanks for organizing this.
Yeah.
Thank you very much for inviting us.
Oh, thank you. Thank you. And so I'll start off with a question for Dr. Lenke. And so your original classification really standardized surgical levels for us. And so why is now the right time to make the jump into this 3D evolution? And what was the most challenging part of adding new modifiers without making the system too complex for a busy or even myself, a simple-minded surgeon?
So, why now? I think, honestly, we would have loved to have done this 10, 15 years ago. And actually, we did have an initial version of this SRS 3D task force that produced this landmark recent new classification, almost 15 years ago, right, Carl Eric? Actually, near my SRS presidency in 2010 and 11. But unfortunately, the technological aspects of having the 3D components of scoliosis well radiographed, visualized, and communicated weren't there basically. And really, it's Carl Eric's work to basically try and, from 2D X-rays, be able to create 3D images that provide us these new 3D modifiers that has allowed us, basically in 2025 / now 2026, to be able to promote this type of new system. I think also there was a great benefit in instead of creating an entirely new 3D system, which I think for anyone, including myself, would have been a lot to manage and understand, that we just kind of took the old system, since it has been so useful, as you mentioned, amazingly, right? It's about the only thing we do that I use that's the same for the last 25 years is the 2D classification system. Everything else in scoliosis care has really changed, right? From hooks to screws, and our correction techniques have certainly changed, but we still use the 2D system to communicate. So we've logically just added on the new 3D modifiers to the 2D system to hopefully make it a lot more manageable and acceptable throughout the world.
So there's a question for Carl-Eric, but Larry just mentioned that you guys really started this 15 years ago, but it sounds like the X-ray field and the engineering had to catch up with your ideas. And so how did you bridge that gap?
Okay, first of all, I will correct. It's not 15, but I think it's more than 30 years. And when I
Well,
was a
3D,
student,
official 3D
I
task
worked
force
with
was
Jean Dansereau and Dr. Ian Stokes on this. So it was in the 80s, no, 1980s and 1990s. So it was more than 15 years ago. But it's true that we are working in this area for many, many years. And there were the reason it took time. I think it's not technology. I think it was accessibility to technology. It was there, but not accessible to everyday's clinic. That was one thing. And then also it was expensive. It was mostly for research purposes and not accessible when it was needed. The other aspect is 3D is the spine, the scoliotic spine is complex. It's 3D as is the 3D is complex. It's a complex thing. So it's not something you can describe only with one angle. It needs many different measurements, and the complexity was how could we describe it? How could we communicate it in a language that is easy to understand and interpret in the clinical field? So I think this is some of the barriers that we addressed recently, and the access to imaging technologies, and also with AI that enable to automatically detect landmarks and facilitate the workflow. I think this is major things. And also, I think now with the complex surgical correction maneuvers, it is essential to rely this on the three-dimensionality of the spine to have a better outcomes.
So, Carl-Eric, you mentioned two things that I think are really important, particularly to me. One is accessibility, and the other is affordability. And
Mhm.
so, a change in this new system, maybe from prior efforts, has been that we no longer require specialized equipment to be able
Mhm.
to get into this 3D classification. So, how does the self-calibration algorithm that was mentioned in the paper make this more accessible to surgeons who maybe don't work in specialized centers?
Okay, so basically, to generate a three-dimensional reconstruction of the spine, we need first the images, but we need also to have the mathematical equation enabling to rebuild the three-dimensional aspect of the spine from the two-dimensional aspects. And so for years, it was difficult, and our algorithms enable to calculate the projection of the radiographic acquisition. And using the two images and optimization algorithms, we can recompute what are the position of the source with respect to the cassette and the patient and rebuild the three-dimensional aspect. So the beauty is that we can do this without having dedicated apparatus. So the algorithms we have developed can be used with any radiographic system. So there are no needs to have a low dose factory calibrated system. We can do this with any system.
Also must
Really
mention, as you
fantastic.
know, Grant, also by interrupt, we've been able to create 3D images of the spine for decades now, but with CT scans, which is way too much radiation. So that's
Mhm.
obviously the critical barrier that's been overcome as well, because we don't want to get CT scans routinely, especially in the pediatric population.
And maybe
These are
another
huge
aspect,
steps forward.
Grant, it was possible to do it, but it was very lengthy to do this because a technician had to identify landmarks manually on
Right.
each X-rays, and it takes time and a lot of time. And so now with AI, automatic detection of landmarks, and the possibility to use any routine clinical radiographs that are acquired in any hospitals, that is a game changer.
I mean, this is fantastic. And it really does kind of democratize how people can use this, not only in the US, but really across the world. And so,
Mhm.
bravo in that regard. And so, Dr. Lenke, the paper in itself highlights that when you're looking at two similar 2D curves, they can have a very divergent transverse morphology. And so, can you speak a little bit about that as you think about planning a case, maybe level selection, or even derotation maneuver selection?
But even before that, Grant, let's talk about even indications for surgery. I think this may change, especially on the lower end of the quote 2D Cobb measurement or the coronal Cobb measurement perspective of indications. Obviously, typically we use 45, let's say 50 degrees as a minimum Cobb measurement, right, for to get insurance approval or for indications for surgery, at least in the AIS population. But there are certainly some patients I think we're going to find who maybe on the 2D measurement have a 40, 42 degree Cobb, but have such a dramatic ORPD and AVR component to their a 3D malformation that may be indicated for surgery because we may find that in natural history studies, those patients will progress and maybe get to a level of pulmonary dysfunction that's really not ideal, right, in later adulthood versus a typical a 45, 50 degree 2D curve that does not have as much 3D malformation to it, right, in a transverse plane. So I think indications for surgery might slightly change over time. And then obviously, as you mentioned, correction maneuvers are definitely going to change. Although again, the interesting thing is I think our correction maneuvers have outpaced the 3D system. I think most surgeons doing this have understand that the spine it is 3D deformed. There is typically an idiopathic curve, less thoracic kyphosis, right, to varying degrees, and sometimes frank lordosis right at the apex, which your ORPD can quantify, and various amounts of rotational component to the individual vertebrae, especially at the apex, right? And that's really what we're quantifying with the two new transverse plane modifiers. So surgeons have adapted various correction techniques, and interestingly, no two surgeons correct things the same, right? There's so much variability, and that's one thing I think that will happen is that although most surgeons who do a fair amount of AIS surgery do think and operate in 3D, the 3D world. It's there's so much variability that is, when there's more variability in surgery and medicine, there's less optimal results. So I think what we're going to do is through communication and quantification of these 3D parameters, we're going to have a better means of knowing which is the best way to optimally 3D correct these deformities. And thus we're going to have more universal, better results consistently for surgeons throughout the world, which is obviously a huge goal and will be a huge improvement in our surgical techniques.
Maybe I can add from the engineering point of view, the three-dimensional, the 3D descriptor and modifiers that we introduce will allow to biomechanically describe the force vectors and the moments that are necessary to perform the correction. So before we were talking in terms of Cobb angles or translation, but even if you perceive the three-dimensionality and you were applying vertebral derotation maneuvers or end-log derotation, they were 3D, but there were no terms to describe this three-dimensionality. I think with this classification, we are introducing descriptors and at the local level, but also at the regional level, which enable to not only address the local vertebral torsion, but also the regional aspect of the spine, which have to be realigned in the sagittal plane. But not just realign, but also restoring the sagittal component as well.
It's a really nuanced explanation. I like that. And Larry, you've also bring up surgical indications. And I think that that's so hard because we're indicating a 3D surgery with a 2D film.
Right.
And there are people, just like you said, who have a 40 or 42 degree curve, or honestly, there's a lot of people who have curves in the mid 30s that will go on to progress in adulthood.
Right.
And we're not sure who's going to progress and who isn't, but it may be that we just weren't looking at it in the right way. So hopefully this classification system over time can give us an inkling about which 30, 35, 40 degree curves are truly at risk.
Right, absolutely. So yeah, although I think again on a higher end, obviously, I don't think it's going to change our indications because, as you know, the 2D correlate of progression of over 50 to 55 degrees of skeletal maturity is pretty strong, right? I think we know that. So that's why I think you're right. From kind of 30 to 50, that's really going to be, I think, a whole new, approach to analysis and potential earlier treatment of scoliosis, either with fusions or fusionless technology, right? I mean, things may change a lot depending on the evolution. Now, we've been waiting for this magic blood test to predict progression of curves, right, for smaller curves, and we may have actually found our magic blood test in 3D imaging, right? If we start putting that towards our natural history studies.
So maybe I would say that I don't think it will dictate surgery, but it will sharpen judgment and have a better description of the complex aspect of the spine, and I think will help to describe and improve the approaches.
I think that's a good point. So to jump in a little bit on the engineering and the technical focus, one of the new terms or novel concepts in this paper is the ORPD, the orientation of regional plane of deformation. And so, Carl-Eric, how does this, in viewing the regional triangle, provide us with more information than, say, a standard sagittal profile or even an axial CT or MRI slice?
Okay, maybe first of all, it's not a new concept. This is something we were using in the research for years. The regional plane of deformity triangles, they are capturing regional aspects of the spine. It's like its spatial orientation. So it helps to it integrates the sagittal profile. It's not just a projection, but it's a three-dimensional aspect of it. It includes the coronal, the sagittal, and the way this curve tilt in space, the spinal curve rotation, the sagittal alignment, into a single geometric descriptor, and how it is positioned in space. So it's not it shifts us for describing angles to describe configurations. It's more like a spatial configuration of the spine.
And so, as we look at the future of surgery, many of us, I think everyone on the podcast, has been involved with enabling technologies to some level, much of that to assist with surgical planning. Most of our surgical planning that's been commercially available to us is really sagittal plane planning. So, how do
Mm.
you see this classification being integrated into surgical planning, maybe as the platforms and the classification mature simultaneously?
Okay, so as you mentioned, most enabling technologies focus on single planes or two times single planes, and but deformity correction is fundamentally 3D, and also it's mechanical, so it's not just geometric. So I think the classification will structures the 3D inputs, and that will enable to improve and enhance the planning platforms. Uh, in the longer time, I see the classification that could better inform the planning tools and be used to become a language for integrating the concepts and the planning. So the classification will be the language, or the descriptor will be the language, and the enabling technologies will be the engine to enable the treatment. So I think it's a transition. Uh, and we are entering an area where 3D pattern recognition will enable better planning, and also will also translate to tools that could also improve the outcomes thereafter. Improve the implementation of the plan also in the OR. So.
What I may add to that is I think the communication of this is so critical, obviously, so we can all communicate on a single platform. That's going to make a big difference, right? Not only surgeons, but research teams, the planning software engineers of all the various companies that are getting into this now. And I think, but there's, it's more complicated. Obviously, these are still static dimensions that are being corrected dynamically. And so I think there is going to be a lag. I mean, obviously, some of the biomechanical aspects of this will also be provided to us in planning software and things, because you may want to, create a certain realignment of the ORPD, but it may be much more difficult than we anticipate, right? Because of either bone screw purchase, or stiffness of the intervertebral segments, or the spine invagination into the rib cage, and all these factors that surgeons are well aware of that often limit our optimized 3D correction. So I think it's going to take a little bit of time to achieve, ideal corrections in everyone. I think obviously we're going to know what the ideal is, which is great. So we at least know what our target is. Right now we don't really know that, right? And then how we achieve that target, we'll be able to better communicate that, because it'll be quantified before and after what the ORPD and what the AVR at the apex is actually has done pre to post op. So, I think it's going to take probably a little longer than we all anticipate, because again, there's the dynamic component of this that always makes things a little trickier and often a little more difficult, as you know, Grant, than meets the eye, right?
So
Absolutely.
maybe one aspect that you mentioned, Larry, is the fact that it's not only geometry. So it's not just
Right.
repositioning the single vertebra in space. They are linked with elements that have mechanical properties. So it's also a mechanical system. So
Right.
something that is not there, but this is missing, but we are not seeing them on the X-ray, are the forces and the rigidity and the stiffness of the component. So I think in the future, it has to be linked with physics-based models that will account for the mechanistic aspects of the spine. And perhaps, as you mentioned, it will not be possible to do everything because everything is coupled. So some corrections will necessitate a lot of energy or forces that won't be able to be addressed. So, and some forces that will be applied will generate counter forces. So I think it's not just so 3D aspect is let's say the one level, first level, and next will be also to integrate the mechanics of the systems.
And that's going to get even more complicated when we have to figure out the force needed to keep our screws
Right.
in place when we start tearing them out of the bone eventually. So
Exactly. I think actually this may frustrate surgeons a bit because everyone is going to know the optimal 3D realignment that you need to achieve, but we're not going to be able to do it, as Carl mentioned in the beginning. I'm not, unless it's a really, really flexible, smallish curve with small ORPD and small AVR at the apex. But so I think surgeons actually may be more frustrated in the R in the near future than they are right now because now we 2D, we get our X-rays to quantify as I did yesterday on a 100-degree
ourselves on
curve,
the
and
back.
exactly, yeah, oohs and ahs. But when we really get our 3D measurements, and hopefully, we're going to get that in the OR quite soon, not just post-op, but hopefully at some point we can also do this intraoperatively, right, to quantify exactly how we're achieving our corrections real time, right, so we can adjust it if possible. So I think it's a very bottom line, it's a very exciting future, and I think the adoption is going to be pretty quick because again, these are not although certainly the ORPD is a regional descriptor that you have to spend a little time on to truly understand. I think the AVR, most surgeons and researchers understand rotation of the individual vertebrae in the apex relative to the pelvis. So I think that's going to be pretty well understood, and it has been understood for a while. But ORPD, once people kind of truly understand that, I think it's going to, and since we added to the 2D system, it's not a brand new system, it's just a modifier component. I think it's going to take off pretty quick. So it's exciting.
So, Carl-Eric, how do you envision that this new classification system will change our research practices, particularly as it's adopted and an incredible amount of data starts to flow in?
It's a good question. So personally, I, I think it won't dramatically change clinical workflow. Why? Because now with the advent of AI and technologies, uh, it will be more and more accessible. And the intent of our group is make it to facilitate the access to surgeons. Uh, but what it will change, it will refine decision making because now with the access to new information, it will slightly enable more advanced approaches for the correction. And also what this classification is bringing is also terminology to describe complex strategies. So I think it will uh, as Dr. Lenke mentioned, will take some time to be adopted, but I think it will probably as soon as we will be able to see the advantage of it and see how it could be applied, I think it will facilitate the day-to-day use of it.
Absolutely. So I've got a final question, and this one's for Dr. Lenke. So what do you perceive is going to be the greatest barrier to implementation of the classification system? And then how do we, as the Scoliosis Research Society, help to overcome that and lead to rapid or semi-rapid adoption?
Yeah, so I think just like the same obstacle that has really led to the development of this and the new system that's taken, as Carl said, over 30 years has really been the technological aspect. So, we still are working on, Carl-Eric is working very hard still on making sure that even with suboptimal X-rays, we can still obtain an adequate 3D model with enough precision, right? Right, Carl, we talked about this a week ago. So, as there's varying X-rays, there's all kind of variability, and right, what the input is to create the 3D models, to be able to provide the proper ORPD and AVR values that we want to make sure are accurate enough. So I think we're still, we don't have that perfected yet, right, Carl-Eric? So I think, we have to get to a point where even with suboptimal 2D X-rays, we can still create acceptable 3D images and transverse plane modifiers that are accurate, right? And then we have to basically, the goal is to get this into every SRS member's facility, right? We're committed to that. The SRS is committed. Millview, the company that's working with Carl-Eric, is also committed to that. We've had several discussions with that company. So, but again, I think that's going to be, and it still is right now to this very day, the limiting feature of this. Carl-Eric has this in his lab on a daily basis. I don't even have this in my lab yet, in my hospital yet. So, I'm not sure when I'm going to get it. So I think that's going to be the limiting feature. But I think it's good though. We'll probably have, in 2026, the goal is to get these new transverse plane modifiers and parameters into everyone's kind of brain set of what they are, how do we communicate with them, how are they formed, how are we going to use this, and then to make sure everyone understands the new SRS 3D system. And then hopefully, soon after that, we're going to basically roll this out that every SRS member can have the software to use in their home institution to create these new 3D models and then actually generate the SRS-Lenke-Aubin 3D classification system. So, we're not there yet. We're very, very, very close, obviously, and we're very excited about it. But that's still something that we're not to the finish line yet. We can see the finish line, right, Carl-Eric? But we haven't crossed it yet. So, but I want to give credit to Carl-Eric and his work. Without his work in his lab and working with Millview, we would not be on this podcast today because although we had these parameters a long time ago, we couldn't get them to a point that could be accessible to the general public. But we're really close now, and it's really exciting.
Yeah. Maybe I may add that technology is challenging, as mentioned, but I think this is not the most important barrier. I think the most important barrier is habit, inertia, workflow, how the people will use it. I think this is the human factor is probably the most important one. But I think adoption will follow if the system really improves clarity and consistency, and the people see the value of it to perform their own surgery and have outcomes. So I think it's very challenging, but it's interesting that we are now at this point, and truly the 3D classification task force is progressing very well, and we look forward to have the system available to the members in the near future.
And I will point out, and this is something that both of you have touched on, we don't have access to do this in the clinic today.
No.
But at some point, as a group, the task force decided that it was important to go ahead and publish the paper and to start the education process around this classification system. And I think that's such a good decision. And it's so important because any change in practice for surgeons can become instantly so overwhelming. And so by educating people early, I think that you're going to get ahead of the curve on adoption.
Right.
And by using the legacy system, it's not a huge jump. I was actually looking at the differences between like the King classification and the Lenke, and I think going King to Lenke in 2D was a bigger jump than going
Right.
from Lenke to the new 3D classification.
Right. And also think, partnering with the SRS, doing this, under the auspices of the SRS was also a great move. And we're very proud of that. And the SRS is the perfect, obviously, organization and platform to promote this worldwide. So it's all win-win, Grant. So it's an exciting time in scoliosis evaluation and treatment.
Absolutely. Thank you both so much for being on the podcast today. We appreciate your time and your expertise. And I know we're going to hear a lot more from both of you in the future.
Sounds good.
Thank you very much.
Very good.